Hello, I'm Dr. Pratyusha. Today I'm here to discuss one of the malpresentations, that is transverse lie. We are going to discuss the topic in terms of definition, different positions that are possible, incidence of transverse lie, the etiology, diagnosis, complications, as well as the management. Coming to the definition. So what is transverse lie? When the long axis of the fetus lies perpendicular to the maternal spine or the centralized uterine axis, we call it as a transverse lie. So this is the image depicting the long axis of the fetus, that is the spine, that is lying perpendicularly to the axis of the maternal spine, which is perpendicular to each other. So this is the image of the fetus in transverse lie. So coming to the position, what are the positions that are possible in a transverse lie? So it is a dorsum anterior position, dorsum posterior position, dorsum superior, as well as the dorso inferior position. So coming to the dorso anterior position, this is the commonest position in 60% of the cases. In this dorso anterior position, the flexor surface of the fetus is adapted to the convexity of the maternal spine. So this is a favorable position and it is the commonest one. The next position is the dorso-posterior position, where the back or the extensor surface of the fetus is adapted to the convexity of the maternal spine. In this case, the fetus is front forwards, that is the flexor surface is facing towards the maternal abdomen, and this is the position where there is increased chance of hand prolapse that can occur. Then we have the dorso-superior position, where the curvature of the fetal spine is oriented upwards, which we call it as a back up position. In this position, the small fetal parts can be palpable through the cervix. And the next position is the dorso-inferior position, where the curvature of the fetal spine is oriented downwards. So, at the cervix, when we do an examination, fetal shoulder will be palpated. So these are the different positions that are possible in a transverse lie. So in transverse lie, this is the presentation, that is the dorsum anterior. This is the dorsum posterior position, where it is possible for the shoulder to be prolapsed down, which we call as a hand prolapse. So in transverse lie, as we know, the lie is transverse. Presentation is the shoulder presentation and the denominator is the scapula. Incidence. Coming to the incidence of transverse lie is 1 in 300 births. It is common in premature and macerated fetuses, and it is 5 times more common in multiparous women than the primigravida because of the laxity. Etiology. So what are the causes of transverse lie? Multiparity, as we have just read. Prematurity, that is one of the commonest cause. Twin pregnancy, second twin mostly will be in a transverse lie. Hydramnios, contracted pelvis, placenta previa, pelvic tumors, where there is no space in the lower segment. Congenital malformation of uterus, that is the arcuate or subseptate uterus, and intrauterine death. Coming to diagnosis, how do we diagnose a patient in transverse lie? The fetus is in transverse lie. So on abdominal examination, when we do an obstetric examination, we can see on inspection the uterus looks broader and is often asymmetrical and not maintaining the pyriform shape. The uterus is broader because neither the cephalic nor the podalic pole is in the fundus, and it is the transverse or it is empty, and asymmetrical because the head and breech are towards each end, where one is at a higher position than the other. So that is the transverse lie, where head is occupying towards one lateral wall of the uterus and the breech is towards the other lateral wall of the uterus. So this is irregularity. So the uterus look asymmetrical. On palpation, the fundal height is less than that of the period of gestational age, and on fundal grip there is no fetal pole, breech or head. Neither pole is being palpable in the fundal grip. On lateral grips, one side on a lateral grip we can find soft, broad and irregular breach is felt on one side of the midline, and on the other side we can palpate smooth hard globular head on the other side. Of this, the head is usually placed at a lower level than that of the breech on one side of the iliac fossa, that is on the lateral ribs. Comingly, then, the back is felt anteriorly across the long axis in dorso-anterior position, or irregular small parts are felt anteriorly in dorso-posterior position. And coming to the pelvic rib, because the lower pole of the uterus is empty, we cannot palpate any fetal parts. So this is the pelvic rib is empty in a case of transverse lie. So most of the palpation we can feel the breech as well as the head in the lateral ribs. Coming to auscultation. The fetal heart sounds are heard easily much below the umbilicus in dorso-anterior position, and it is however located at a higher level and indistinct because in dorso-posterior position. When the dorsum is back, the exact position of the fetal heart cannot be located. And diagnosis is by a ultrasound examination where we can see the exact presentation of the fetus. So after ultrasound, then we go with the examination, that is the vaginal examination, which is done during pregnancy. During pregnancy, in a transverse lie, when we do a vaginal examination, the presenting part is high that it cannot be identified properly. But sometimes small fetal parts like the finger buds or the cord can be palpable and small limb buds can also be sometimes palpable in a vaginal examination. But most of the time the lower pole or the lower segment will feel empty. During labor, there is formation of elongated bag of membranes, and the shoulder is identified by palpating the following parts. That is the acromion process, the scapula, clavicle as well as the axilla with the intervening ribs. So this all structure is described as a gridiron feel when we are doing a vaginal examination during labor. And we can also sometimes palpate a prolapsed arm in case of a shoulder presentation. So what is the clinical course of labor? The fetus is in transverse lie and the patient is in labor. What is the clinical course that is following next? There is no mechanism of labor in transverse lie, and an average size baby, it fails to pass through the pelvis. So when there is no mechanism of labor, what is happening? Mostly the events that can occur are unfavorable in a term pregnancy, but some favorable events can occur in a severe preterm pregnancy or in a dead fetus. So what are the unfavorable events that can occur, which are most common in a transverse lie? First is a premature rupture of membranes. There is premature or early rupture of membranes in a case of transverse lie because there is absence of the ball valve mechanism that is there, and because of the ill fitting of the presenting part in the lower segment. That is why there is early rupture of membranes, and because of the early rupture of membranes there is increased chance of hand prolapse with or without cord prolapse. And after the prolapse, because the membranes are ruptured, there is always increased risk of ascending infection from the lower genital tract to the uterus and at increased risk of chorioamnionitis. Then if the patient progresses in labor without diagnosis, then there is increased chance of obstructed labor because of the contraction of the upper segment and dilatation or distension of the lower segment, which results in formation of a retraction ring, which we call as a Bandel's ring. This obstructed labor can further lead to neglected shoulder presentation if not diagnosed, leading to retraction ring followed by maternal distress, sepsis, which is superimposed by sepsis or infections. And in primigravida, what happens is after a period of brief contractions, the uterus goes into quiescence, that is, will lead to obstructed labor. But in cases of multigravida, what is happening is Because the uterus contracts and contracts, it will finally end up in a ruptured uterus. That is the complication mostly in a multigravida. So after the unfavorable events which are common, we come to the favorable events which are rare. So what are the favorable events? They are spontaneous rectification or version, where the oblique or transverse lie is converted into cephalic or breech presentation. Then it is spontaneous evolution. That is, the baby is in transverse lie and is delivered like that. Then it is spontaneous expulsion, which we call as conduplicator corpore. These events are very rare and can occur only when the baby is premature or macerated. So what is spontaneous rectification or version? It usually occurs in early labor with a good amount of liquor and the baby is small and movable. And the contracting uterus, it forces the head or breech from one iliac fossa to lie in alignment with the brim. And with good amount of contractions, the lie is changed from oblique to longitudinal with vertex presentation, which is called rectification, or breech presentation, which is called version. So the lie is converted to longitudinal and it can either be vertex or breech. And this is more common in a multiparous women. Then we have spontaneous evolution. So what is happening in spontaneous evolution is that the arm is usually prolapsed after the membranes have ruptured and the head lies on one iliac fossa. The trunk and breech are forced into the cavity and the neck is markedly elongated. So after the hand is delivered, the breech and trunk are expelled first, followed by delivery of the head. This requires very strong uterine contractions. And the third mechanism is spontaneous expulsion or conduplicator corpore. It is a very rare mechanism and it occurs only in premature and macerated fetus. The fetus is expelled doubled up with chest and abdomen approximated and the head and feet are delivered last. So these are the rare three mechanisms, that is spontaneous rectification or version, spontaneous evolution and spontaneous expulsion. Management. So how are we managing a patient with transverse lie? Transverse lie with intact membranes and a live fetus. So before the onset of labor, what we can do and what we can do if the patient is in labor. So before onset of labor, in the absence of contraindication for vaginal delivery, we can proceed with the external cephalic version at approximately 37 weeks of gestation. If recurs, then we can attempt a repeat external cephalic version at 38 to 39 weeks and induce labor. If the patient is declining external cephalic version, then a cesarean delivery is performed at term. But because of the malpresentation and increased risk of complications like hand prolapse or cord prolapse, it would be better to admit the patient for the hospital stay. Approach in early labor. In early labor, if it is a single fetus in transverse lie with intact membranes, live fetus and good amount of liquor, ECV can be advised if there are no contraindications. And if the version is successful and the cervix is dilated, amniotomy can be performed after the stabilizing oxytocin drip. If ECV is unsuccessful, then we can proceed with the cesarean delivery. Approach in active labor. When the patient is presenting in active labor, there is no scope that we can do an external cephalic version. So our option would be performing a cesarean section. Then transverse lie with ruptured membranes and live fetus. If the gestational is more than 34 weeks, then the option would be to perform a cesarean delivery. And if the gestational age is less than 34 weeks, expected management for steroid coverage and perform a cesarean section. If the gestational age is between 28 and 34 weeks, delivery rather than expected management may result in better neonatal outcome with a course of antenatal steroids. transverse lie of second twin after delivery of the first twin. This is the only indication where an internal podalic version to breech presentation followed by breech extraction can be done. This is the only obstetric indication where the internal podalic version is advised in modern day obstetrics. Transverse lie with fetal demise or a pre-viable fetus. Before labor or early labor, ECP can be done to achieve a longitudinal lie regardless of the membrane status, followed by induction of labor because the fetus is already demised or it is a pre-viable fetus. In active phase of labor, internal podalic version can be done by an experienced practitioner. If the fetus is extremely small and dead, the body may collapse and it can be delivered as a conduplicator corpora, passing through the pelvis. Thank you.